Hi everyone, I'm Sujata, founder of Grace USMLE and USMLE author at Achievable. In this video, I would like to go over some important concepts on pneumothorax. So what is pneumothorax? Pneumothorax is the abnormal accumulation of air in the pleural space. Under physiological conditions, the intrapleural pressure is always negative. When air enters the pleural space, the intrapleural pressure becomes more positive. The negative intrapleural pressure is vital to keep the small airways and alveoli open. It may lead to partial or complete collapse or atelectasis of the lungs. Pneumothorax presents with sudden onset of dyspnea, tightness in the chest, pleuritic chest pain. There may be cardiorespiratory collapse in tension pneumothorax. What are the types of pneumothorax? Pneumothorax is of 4 types. It may be primary, secondary, traumatic, or tension pneumothorax. Primary spontaneous pneumothorax is caused by the rupture of subpleural blebs. It is seen commonly in young, tall, and thin individuals and is more common in smokers. It is associated with mutations of the FLCN gene. This gene codes for folliculin, which is involved in connective tissue formation. Secondary spontaneous pneumothorax can be seen with underlying conditions of the lung, such as bronchiectasis, tuberculosis, asthma, COPD, etc. Some systemic disorders of connective tissue like Ehlers-Danlos syndrome, Marfan syndrome, rheumatoid arthritis, and ankylosing spondylitis are common causes of secondary spontaneous pneumothorax as well. Traumatic pneumothorax can be a result of penetrating trauma to the chest. Invasive procedures like lung biopsy, mechanical ventilation, subclavian vein catheterization can also lead to pneumothorax. Tension pneumothorax is a life-threatening disorder which is caused by penetrating trauma to the chest or the lung. The resultant defect acts as a one-way flap valve that allows the air to get into the pleura but doesn't allow it to escape. As a result, air collects in the pleura under high tension. The positive intrapleural pressure interferes with venous return to the heart that leads to cardiorespiratory collapse and shock. On physical examination, breath sounds are absent on the affected side, and there is tracheal deviation to the opposite side with mediastinal shift. The point of maximal impulse shifts laterally, and JVP is elevated. The X-ray shows tension pneumothorax on the right. The homogeneous black shadow on the right is due to air in the pleural space. You can see absence of any kind of lung markings in the area of the pneumothorax. Just to the right of the sternal border, you can see the border of the collapsed lung. The X-ray also shows mediastinal shift towards the left, and there is tracheal deviation also towards the left. Let's review management of pneumothorax. Management will depend on the type and severity of pneumothorax. In primary spontaneous pneumothorax, if the size of the pneumothorax is less than 50% of the hemithorax and the patient is asymptomatic, then they can be managed by observation alone. Severe cases will need a tube thoracostomy. In secondary spontaneous pneumothorax, spontaneous regression is less common. Management is by high flow oxygen. If the size of the air rim is 1 centimeter or less, then it can be managed conservatively. In severe cases, chest tube drainage or aspiration thoracostomy may be needed. For treating tension pneumothorax, a large bore needle is inserted into the second intercostal space in the mid-clavicular line as an emergency procedure. It should be followed by tube thoracostomy. A vented chest seal should be used to cover any penetrating chest wounds. All cases of pneumothorax should be followed up with serial chest X-rays. Thanks for watching. Hope you liked today's video.